Hi, I'm Hafiz. I'm a researcher in public health. I'm excited to introduce and discuss with you the topic of health financing in Indonesia. With a growing economy and commitment to improving health outcomes, Indonesia has its unique challenges in finding the best health financing strategies. I will share the Indonesia context, health expenditures, Indonesia health insurance, and health technology assessment. Let me start with my own experience as a medical doctor more than a decade ago, where I worked in a rural area in Indonesia. I worked under a non-government organizations and practicing in primary care. So, in terms of health financing, you can imagine that the NGO got funding from multiple sources, such as donations, sponsor, out-of-pocket from the patient, and also medical supplies from government, especially for the vertical programs such as malaria. All sources were pulled in one bucket in the NGO. And the NGO purchased health by giving a fixed monthly salaries to the health workers, including me, and pay all the operational costs to buy medicine, supplies, and maintenance. However, it is just a small picture of Indonesia. Indonesia is a diverse country made up of more than 17,000 islands with more than 500 districts. The estimated population is 270 million, making Indonesia as the fourth most populous country in the world, and 60% of the populations are in Java Island. For example, Jakarta and Papua are two different regions in Indonesia, both with distinct characteristics. Jakarta is the capital city and the largest metropolis in Indonesia, located on the Java Island. It is a major economic and political center of the country, with a population of over 10 million people. Jakarta is known for its modern skyline, bustling street, and cultural diversity. Papua, on the other hand, is a province located in the eastern part of Indonesia and known for its diverse culture, rugged terrain, and rich natural resources. It has a much smaller population compared to Jakarta, with a majority of its residents living in rural areas. There is an improvement of health indicators in Indonesia. However, there is a wide variation across the country. In 2021, life expectancy at birth is 73 years on average with wide variation. Maximum in Yogyakarta province is 75 years and minimum in West Sulawesi is 65 years. In terms of health workers, 63% of the total medical workforce is located in Java, Bali Island. Based on the proportion of public health centers with the availability of doctors, Papua is the province with a shortage of doctors. Meanwhile, all health centers in Yogyakarta and Riau have the minimum standard numbers of doctors. I will give an overview of health facilities look like in Indonesia. Health facilities in Indonesia range from public hospitals to private clinics. Public health facilities in Indonesia are funded by the government and are generally more affordable compared to private health facilities. There are more than 3,000 hospitals in Indonesia, and 63% are privately owned. According to the capacity of hospital services, there are 4 classes of hospitals in Indonesia. Class A hospitals are the largest hospitals, mainly for national referrals, to D as the smallest hospitals with a limited specialist. Hospitals have a different types of ward in inpatient services, from VIP mainly with 1 bed in private room to class 3 with 6 beds or more in 1 room. Primary healthcare in Indonesia provide basic healthcare services by general practitioners. In regards to ownership, there are private and public primary healthcare. In 2021, there are more than 10,000 public primary healthcare called Puskesmas, which are located at the sub-district level with a network called Puskesmas Satellite or health posts in villages. To reach remote and underserved areas, the government and non-government organizations have set up mobile health clinics that bring healthcare services directly to the people. To ensure the health system are efficient, effective, and responsive to the needs of the populations, health expenditures measurement is crucial. Healthcare spending is ballooning over the world, including in Indonesia. Health expenditure per capita has been risen almost threefold, from $42 in 1995 to $125 in 2019. However, it's considered to be low, just below 3% per GDP compared to other countries in Southeast Asia such as Thailand almost 4% and Vietnam 5%. But let's see the good side. From the picture, the out-of-pocket decreased dramatically in the last 10 years from 60% to 35%. Also, the government spending on health has increased, leading to a dominant share, almost 50% in 2021. It happened especially after 2014 when the national health insurance was implemented. So let's take a closer look at the national health insurance in Indonesia we call JKN. Prior to JKN, Indonesia had 3 health insurance schemes for civil servant, the formal employed sector, and the poor. All 3 schemes had different benefit packages. With the 3 schemes, there was a population gap that cannot be covered under health insurance. There are Indonesian people in the self-employed or informal sector. They cannot afford to buy health insurance, and access to healthcare in Indonesia become limited. Therefore, after 10 years of regulations issued, the government of Indonesia merged the schemes into JKN, and self-employed people can pay with affordable contribution premiums because JKN covers a large number of the population. However, some academics argue that having one scheme means that the premium contribution for the poor, which is subsidized by the governments, mostly utilized by the non-poor people, especially the self-employed schemes, where they can have better access to health facility or more aware on health issues. What do you think? Do you prefer keep it to be multiple pool prior to JKN, or single pool, or no pool at all? Single pool has advantages. This approach can lead to more efficiency in managing resources, and it promotes equity, as all individuals contribute to the pool and all have access to the same level of health coverage. Multiple pooling, on the other hand, involves separating the health insurance funds into different pools, such as separate pool for low-income individuals and another pool for high-income individuals. The advantage of this approach is targeting specific groups that need the most support. The implementation of JKN by BPJS Kesehatan in 2014 aimed to increase access to healthcare services, improve the quality of medical treatment, and reduce the financial burden on the patients. In December 2022, the program covers almost 250 million people, and most of it's funded through contributions from the governments or subsidized scheme, especially for the poor. Even though there are different types of membership, JKN provides access to the same range of health services, including inpatient and outpatient services, maternity care, and emergency services. The difference only the type of wards depend on the level of premium contributions you choose. More than 23,000 primary care and almost 3,000 secondary care are contracted by BPJS Kesehatan. In 2021, almost 400 million utilizations or 1 million visits or admissions per day with more than 90 trillion Indonesian rupiah or $6.2 million. In terms of payment mechanisms, primary care use capitations with fixed monthly payment per JKN beneficiary regardless of the actual number of medical services provided. Also, an additional fee schedule payment mechanism for limited services such as maternal health care and diagnostic tests. While at the secondary care, JKN used the diagnostic-related group as a bundle payment, which we called INA-CBGs. This is designed to encourage primary care providers to focus on preventive care and to ensure the secondary care providers have sufficient resources to provide comprehensive care to patients with more complex health needs. A study by Hidayat in 2016 shows that INA-CBGs at secondary level reduce the cost of pharmacies and encourage hospitals to use generic drugs. However, unintended consequences also happen, where primary care tends to refer patients to hospitals and hospitals tends to keep the patients. This implies high cost and proportion at the secondary level, around 80% of JKN healthcare expenditure. Given the comprehensive benefit packages and its high cost at the secondary level, economic evaluation, particularly cost-effectiveness analysis, become a big concern to ensure the value for money of any technology adopted. The Health Technology Assessment Committee of Indonesia was established in 2014. The aim of HTA Indonesia is to inform decision-making on the use and reimbursement of health technologies and to ensure that the health technologies are used in an effective, safe, and cost-effective manner. The HTA studies were carried out by both technical staff of the HTA committee and HTA agents in universities, both with funding from the state budget and support from BPJS Kesehatan. Until 2020, the HTA committee has conducted 15 studies. I'm one of the agents involved in 3 studies. Those were phacoemulsification cataract surgery techniques, HPV-DNA for the cervical cancer screening test, and trastuzumab adjuvant in early-stage breast cancer in Indonesia. The Health Technology Assessment Committee is facing challenges. The committee is under the Ministry of Health, which not fully independent, thus it might impact the ability to make clear and objective decisions. Lack of resources, including budget, infrastructures, and technical capacity to cope with the increasing demand, data availability to carry out HTA studies, and inadequate stakeholders' involvement, including public and industry. In conclusion, health financing in Indonesia is a crucial aspect of the country's healthcare system. By ensuring that the necessary resources are available to provide quality care to all citizens, health financings play a critical role in promoting health and well-being. Over the past few years, Indonesia has made significant progress in improving its health financing system, including the establishment of the National Health Insurance Program and the Health Technology Assessment Committee. These initiatives have helped to increase access to healthcare and to improve the quality of care. However, there is still much work to be done to ensure that all citizens have access to the care they need. To this end, it is important to continue to focus on improving healthcare financing in Indonesia and to work towards a sustainability and equitable system that meets the needs of all citizens. Thank you for your attention, and I hope that this overview of health financing in Indonesia has been informative and useful. I'm happy to discuss further with you all.